Hi guys, welcome today again. So today I've tried to get Tim to stay longer with us and he's kindly agreed to us because he wants to help so much. And we're doing a third video now, and this is going to be on the shoulder. So something that we didn't anticipate we'd do, but Tim has kindly offered to say he would do it. So we're going to have a quick discussion about that because I guess that's one joint we haven't really talked about. And very important, these conditions we talk about, frozen shoulder, where we have a lot of builders who actually come in quite desperate for a quick fix, sometimes things like steroid injections, just because sadly the capabilities with the NHS and getting a physiotherapist to help straight away is sometimes difficult. Or people for long-term wise, they're taking medications for months and months and months, and they're not really getting movement. And what's terrible to hear with a lot of our patients, especially some of the older generation patients, is simple things like combing their hair or having a shower or even wiping themselves after going to the bathroom. They just learn to live with it, which is terribly sad when I sometimes feel as a clinician we can do a lot more. So it would be great to get your thoughts, Tim, on kind of what shoulder pain is, do you see it often, and also what things we could do to help.
Shoulder pain is very prevalent. It affects about 2.4% of the UK population.
Okay.
And it is a big cause of pain. It tends to be the third most common cause of musculoskeletal or joint and muscle pain after back and neck pain.
Okay.
And at one point knees were more prevalent, but actually in the last 10 years, 15 years we've seen a slight increase towards shoulder pain. And shoulder pain, it's very, very common. It's very common in all ages, from mid-20s really onwards, but especially the over 50s and 60s. This is a very complicated joint. It's complicated because there's so many different ranges of movement. You can move the arm in so many different angles and directions, and there's so many small muscles around the area. So this is the main shoulder joint. It's called the glenohumeral joint. That's named after the glenoid, which is the cavity, and the humerus, which is the upper arm bone. It's a ball and socket joint, so the ball effectively fits into the socket. Now, a big cause of problem occurs because of these four muscles, and one in particular is a real problem. These muscles are called rotator cuff muscles. Now, one in particular is known to be a real pain, and this affects your sort of over 50s category of patients. Now, there's a muscle that sits here, and it sits in this groove here. And this muscle is called the supraspinatus. It's a rotator cuff muscle. And the tendon of the supraspinatus tends to attach to the bone here. Now, in a very simplistic way, what can happen is as the tendon tends to slide under the joint here, as you lift your arm up or you rotate your arm behind you, as that tendon slides, it can unfortunately get a little bit caught or pinched. And if it gets pinched, it can be pinched under here or just under here. If it becomes pinched, then you can get inflammation and this tendon swells. And if this tendon swells, it becomes very hard to actually lift your arm. And this is a condition we call as an umbrella term, shoulder impingement. Now, there are different names for it. Some people call it subacromial pain syndrome, but it's probably getting a bit technical. So we'll just know it as a pinched tendon or a shoulder impingement. And this tendon gets impinged. It can be caused by a little bit of osteoarthritis at this joint, a bit of wear and tear at this joint, and then it can cause problems for up to 2 years. So it's a very chronic problem. And what patients tell us is they have real trouble with three things. They have trouble sleeping on their side, and they have trouble lifting their arm above their head, and they have trouble reaching behind their back. Or what we'd call the bra strap or tucking your shirt and your trousers. If you have those symptoms, then you might have this impingement. And the other condition that can affect shoulder, there's lots of conditions that can affect shoulders, is you can have something called frozen shoulder. So what frozen shoulder is around the joint here is a capsule. And this capsule holds the fluid in your joint. After trauma to the shoulder, so following a dislocation or landing badly on the shoulder or following shoulder surgery, this capsule around the joint can shrink and adhese. Okay, and when it shrinks, it makes moving the arm really, really difficult. If you notice you're really getting severely restricted in arm movement, then you might be suffering with frozen shoulder. And frozen shoulder, like shoulder impingement, it takes a long time. It's very, very painful because these adhesions are quite sensitive. It can take, anywhere up to 24, 36 months to actually resolve. They need a lot of physiotherapy input. Often they need injections as well to support them. It takes a long time to get them better. So they're two complicated chronic shoulder pains that cause a lot of difficulty for patients.
Thanks, Tim, for that. That was a great demonstration, better than doing it on me. So the last question I have, Tim, is in the last few months, I've actually, have to be honest, as I've been doing a few more steroid injections into the shoulder than I usually do. Main reason being patients are really struggling, sadly, financially with this current climate, and they're desperate to work. They're struggling in all kinds of ways. Funding for the household, providing food, and I sympathise with them. We're fortunate in probably some of the work we do that we can manage through this difficult time, but they're desperate to get back to building work, to get back to lifting things. So they have been requesting that kind of quick fix, and typically in a pre-COVID state, we would have said, no, let's try painkillers, see the physio, let them work it and sort it. What is your take on steroid injections in these areas? Would you recommend it? Do you think, no, we should hold fire and then try and push them more towards just waiting and seeing you guys, or do you think it's okay to actually do these injections?
I generally believe that it's absolutely fine to do injections. I'm quite supportive of injections because I think an injection is just one part of the treatment process. Now, an injection may not necessarily cure the problem, but it can certainly give patients a big step forwards. Now, the problems come when you have repeated a large number of injections. If you're having 2 or 3 injections, it's extremely low risk. If you're having to go back and have constant injections, this is not what we would do. So this would not be prescribed. And we also, we're a little bit more cautious if we know there might be a little bit of a tear in the shoulder as well, and we might be a little bit more cautious. It doesn't say it's a contraindication to injections, but I'm fairly pro injections because the thing is these tendons can get quite inflamed, and it's quite hard to break that inflammatory cycle. So what the injection does is it helps to reduce the inflammation. And it also provides some anaesthetic qualities, so it can help numb the pain. What that does is it buys you a window, and during that window, it lets you move your shoulder, and it gives you pain relief, so you can start, using your shoulder more, which is what we want you to do. Frozen shoulder and then these sort of problems, they get worse when they're not used. So I think there's definitely a place for injections, and I would support their use. With an exercise program as well in backup. So you do the exercises after the injection. You can also use ice, a pack of frozen peas for 10 minutes every day. Wrap it in a tea towel on the shoulder to help reduce inflammation. It's one part of a treatment modality that I think can be very useful.
So our final part of the shoulder video is just doing a few stretches or exercises for that shoulder. So maybe I've got a problem with my left shoulder. I've come back from work, it's causing a bother, maybe I can't actually function at work. So what can I do in the position I'm in to help me?
Let's first of all just get the shoulders, let's get it mobile, let's get it moving, okay? So I really like an exercise called the pendulum exercise. And what we would do is we would just support ourselves on a chair, and we would just gently let the arm swing, okay? So you lean right over, and you let the arm kind of rotate on its own movement. That's it. So it's really gentle. Okay. There you go. And you're just going to let the arm gently swing. So what this is it's as close as you can get to a passive mobilisation of the arm. So you're actually just mobilising your arm really, really gently.
Right.
You can
Simple
do this.
As that.
Yeah, you do this for about a minute in both directions, 3 or 4 times a day. It's a really nice exercise just to get the shoulder moving.
Right.
The second exercise that I really like is called rock the baby. Okay. So a lot of people have trouble with taking their arm out to the side. So we call this movement abduction. So it's what we do is we let's say this is your bad arm and this is your good arm.
Yeah.
So the good arm supports the bad arm.
Yeah.
And you're just gently going to rock the arm out to the side. Now again, keep it within your comfort zone. So keep it comfortable. But as you get less pain, you can start to get more range of movement.
Great. Perfect.
Now the next exercise, I really like it, but I'm going to need you to squat or kneel down a little bit.
Okay.
So if we just
Like
go,
this?
yeah. Actually, if this go on to
Yes, please.
good. Yeah. My next exercise that I really like is a flexion exercise to the shoulder. So our bad shoulder is the left arm. Now a lot of people have trouble lifting their arm above their head. So what we're going to do is we want to get the arm to go above the head, and we call this a passive flexion exercise. So we use our good arm to support our bad arm,
Yep.
and we're going to lift it just to 90 degrees or so, and that back down. Now you stop when you get the pain. So you go up to the pain, stop, and then come back down. You repeat it 10 times.
Okay.
Now, just to give you an idea of what happens, after a few days, you'll start to go higher. Okay, so you can start to take it higher. And after a couple of weeks, you'll go a bit higher. And after 3 weeks, 4 weeks, 5 weeks, 6 weeks, 7 weeks, 8 weeks, 9 weeks, 10 weeks, 11 weeks, 12 weeks, you see repeatedly doing this exercise, you can gradually get the arm going higher and higher.
Right.
Yeah, and that will help mobilise the arm, reduce some inflammation, and get that shoulder joint really moving up.